Most hospitals rely on thick, written emergency response plans. However, a static binder offers little protection against the fluid chaos of a flooded corridor. In a mass casualty event or a sudden infectious outbreak, doctors and nurses rely on their training to treat patients. Individual clinical skills are rarely the weak link. Breakdown occurs between departments. The emergency room struggles to manage overflow, the lab backlogs without a communication plan, and logistics teams lose track of critical equipment like extra ventilators. To determine if a hospital can actually handle a disaster, leadership must put these communication networks under intense pressure before real lives are at stake. Planners have several ways to test these systems. Tabletop exercises allow department heads to discuss a scenario in a conference room. This approach efficiently reviews policy, but lacks the friction and stress of a live emergency. Drills provide a more practical test by training single, isolated functions, such as a rapid response team practicing sample collection or resuscitation. Full-scale exercises represent the high end of simulation, deploying actual equipment and mock patients into the field. These offer high realism, but require enormous resources, limiting how often they can be performed. This text defines a highly effective middle ground, the functional exercise, or FX. An FX is an operations-based exercise that tests multiple functions of an operational plan. It evaluates how an emergency operations center coordinates under intense time pressure, without the need for physical resource deployment. The process begins with strict operational objectives. Planners might test how the logistics team sources emergency beds, or how the intensive care unit communicates with the blood bank during a sudden supply shortage. By targeting the decision makers, these exercises induce the mental and psychological stress of an overwhelming situation. This reveals leadership and coordination flaws much faster than setting up mock triage tents. An FX relies on an exercise management team with specific roles. Controllers dictate the overall pace, facilitators feed information to participants, and evaluators observe every action to identify systemic weaknesses. Planners use time jumps to manipulate the narrative, fast-forwarding from the first hour of a response to test recovery efforts 3 weeks later. Facilitators drive the action using injects, scripted prompts like an urgent phone call or power failure that require immediate response. These events form a master inject matrix, a grid detailing when information arrives, who delivers it, and which department must act. The exercise begins with Start X. Initial injects are often vague, such as a single report of a chemical spill missing key details. This replicates the initial fog of war common in any crisis. This rigid architecture of timed information allows facilitators to observe how staff react to unpredictable, compounding problems in a controlled environment. Controllers escalate the stakes. A hospital might face 50 new patients arriving simultaneously, while the lab reports a total failure of its blood analyzers. The lead controller monitors participant stress in real time. If the staff manages the situation easily, facilitators increase the frequency of injects. If participants are paralyzed by the load, the controller slows the pace so they can regroup. The simulation reaches a climax of conflicting problems. The pharmacy might report a critical antibiotic shortage at the exact moment a social media rumor sends a panicked crowd to the hospital doors. This photograph captures the intensity of an emergency operations center during peak activity. Managing this volume of data on multiple screens is designed to flood information channels until interdepartmental communication begins to fracture. Functional exercises serve as controlled stress tests. Planners intentionally push a hospital's systems to the snapping point to reveal their absolute operational limits. When the controller calls End X, the immediate pressure breaks. Participants often experience a visible sense of physical relief when the simulation concludes. The most valuable insights emerge during the immediate debrief, known as the hot wash. Evaluators present objective data recorded during the exercise. They show exactly when bottlenecks formed or which departments failed to receive critical alerts. The team uses plus-delta analysis to categorize the results. They discuss successful workflows, like an effective triage expansion, alongside deltas, the specific procedures that failed and require revision. Identifying a systemic failure inside a safe simulation environment is the highest form of operational success. Vulnerabilities exposed during the hot wash often point to flaws in the original response plan. If the security team and clinical units follow conflicting instructions during a simulation, the written policy itself is the problem. These lessons mandate physical updates to hospital policies. Facilities rewrite their operational workflows, update contact chains, and fix software bottlenecks identified during the stress test. Leadership teams walk away with the mental muscle memory required to navigate a severe crisis together. Effective preparedness relies on a coordination system that is constantly challenged and refined. It must be repeatedly tested in a safe environment